Good evening, everyone, for those in the US and Europe. Early good morning for those going into Middle East and Asia, and good morning for those in the Pacific, Australia and New Zealand. Presenting today on a pet topic of mine, which is combining motion technologies with fusion-based procedures in idiopathic scoliosis. And it's a niche area. I know that not everyone looks after pediatric deformity, but thank those who are able to join me for doing so today. And please fire in any questions. I see Andrew. Hey, Andrew, how are you? Fire in any
Hey,
questions in the chat box. And yeah, I'll try to get to them when I can. Thanks for joining us, Andrew. So I will just start sharing my screen and just get onto this. Okay, so I'm talking today on hybrid surgery in adolescent idiopathic scoliosis, and we sort of extend this into some other conditions as well. We've done quite a few sessions on the basics of AIS. Ali Barsh has an excellent one. And look, if you want other resources aside from this channel, there's a guy called Dr. Derek Lee who's also appeared on this channel, who has a bunch of videos and resources on the understanding of idiopathic scoliosis, a whole lot of surgeons, orthotists, exercise therapists, and that's a good resource as well. But we know, I suppose, from our bracing experience that growth modulation does work for pediatric spine deformity. So the numbers down the bottom for this particular young lady are her age at presentation, and she was 13 in 2017 when she came in with a 22-degree right thoracic curve. You can see that she's been braced, and fortunately, because her curve was flexible and she's a dancer, she's been braced down to 13 degrees. She's been braced. And then at 15 years of age, her curve is 15 degrees, and she's getting very skeletally mature, as a lot of young ladies are at that age. And long-term follow-up at 17 years of age shows that despite being out of the brace for over a year, in 2021, her curve is maintained at approximately 9 degrees. And so here we have a curve that without surgery, we've been able to reverse, and we've reversed it through applying pressure on the spine with a brace during growth. So the theory is there for growth modulation, and we know that not only they help in scoliosis, and there's the braced RCT amongst others, but they also help when there's kyphosis. But the effectiveness of bracing appears to be a kind of maximum of 40 degrees. And there are isolated cases where we can see success with bracing above that value, but 40 degrees seems to be a sort of cutoff for most surgeons to consider surgical intervention. And in the past, that has generally been a spinal fusion procedure for progressive scoliosis. So this is just an example of a patient that I've followed up long-term that's been braced for kyphosis, and you can see the presenting x-rays there, and there is a postural element there, but underlying all that is a degree of Sherman's disease, and this is in the middle of brace treatment is the middle film, and at the end of brace treatment, you can see a bit of flattening of the ribs is the final film, and I've been following this patient now for 10 years, and they've maintained that shape. In fact, their ribs actually sprang back a bit at last follow-up. And so again, another example of growth modulation of the pediatric spine with external forces applied. So just a refresher as to what is VBT or tethering. Tethering requires anterior or anterolateral access to thoracic or lumbar spine. And basically, you're putting screws in the convex side of the curve. So if you've got a right thoracic curve, you're going from the right side to put vertebral body screws in, which are very similar to pedicle screws, but they're generally monoaxial. You then, after all your screws are placed, and often use a staple, just like you do in an anterior fusion to prevent ploughing of the screws because the vertebral body is not as strong as the pedicle, you're basically placing a cord, which is made out of a peat. It's essentially polymers woven together, and you're tensioning that cord. And so you do get some immediate correction on table. You are using this effectively as an internal brace, and you're using the theory of the Hughes-Volkmann principle and Wolff's law, which affect the asymmetrical bone growth of the spine. And by applying this technology at the right time, you can get excellent results. And there are current indications for the tether, and these do get stretched, but these are the US-based indications. Essentially, it's a curve with a Cobb angle that's been progressive of 30 to 60 degrees. And I think most surgeons would say it has to be flexible, at least 50%. And they need to have failed bracing or be intolerant to brace wear. So this is the current sort of humanitarian device exemption available in the US for vertebral body tethering. And this is an example of a curve. The lumbar curve had just ticked over to 40. Thoracic was about 38. And the family chose to have both curves tethered. She had a lot of growth remaining, this girl. And she's had a fantastic long-term result, returned to high-level dancing. So these smaller curves that are highly flexible, we seem to get great results with tethering by and large. But of course, there are problems and complications. No technique is perfect. And I think that very much applies to tethering. So when we look at some of the biggest series of tethering, this is one of them published in Spine from Stefan Parent, Feroz Mianji, co-authors. They looked at 112 cases with a 2-year minimum follow-up, and they had an almost 20% revision rate to fusion. Sometimes the tethers also had to be released for overcorrection. So I think if we look at large series on selective thoracic fusion in high volume centers, we do see that the rates are less. The rates of fusion, particularly in the thoracic spine, the reoperation rates are somewhere between 5 and 10%, depending on the center and the study you read. Now, we are getting better at tethering since the first report of Feroz Mianji, Stefan Parent, and other reports by Amir Sandari, who from the Shriners in Philadelphia, who also has large case series. His revision rates are around 15% at 2 years. So this is a series from Grenoble in France by Aurélien Corvasseur, who's a friend and colleague of mine, and his revision rate in this series at 2 years of about 50 patients is about 10%. And half of those are for overcorrection, so he's just gone in to snip the tether, and the other half are for conversion to fusion because of failure to adequately control the curve. So I think with time, indication, refinement, and technology, we are getting better at this, but it's certainly not for every patient. And a lot of patients will come in, not meet the indications for the tether, but still want some sort of motion preserving technology. So we do see failure, and this is one of my cases, and I tell patients still it's a 15 to 20% clinically significant failure rate for thoracic VBT in most studies. Cords probably fail at a much higher rate than this, but if they do their job and modulate the growth and then fail down the track, then that is not a big issue all the time. So this girl failed. You can see her initial result. I'll go back one, which is quite good for about a 63-degree curve, and then failed, and actually revised her by doing redo cords with a mini fusion at the apex across those two discs where the cord failed. But one of the big concerns that we have about tethering is if we do this operation, we're trying to avoid a fusion. But if it fails, you may well end up with a fusion, a long posterior fusion. So there has been a number of tethering surgeons in this group have published a dissection on what happens after VBT is salvaged to a posterior fusion. They actually found that on average, almost 2 more levels were fused in their series than if you'd done it in the first place as a regular posterior fusion and not tethered. So I think that's something that's really important. They're very good surgeons, and they're actually ending up fusing a little longer than what they would have otherwise. And so I think patients need to be aware of that. And look, revision is always a concern. Any anterior column procedure, including fusion or tethering, can actually be kyphogenic. And even though AIS is generally thought of as lordoscoliosis, this is a particular concern in the lumbar spine, and it can be very problematic with large curves. And Britain's Got Talent, America's Got Talent TV show, Simon Cowell. In the British version, there was a girl with quite a large curve that was in the 90s. And she went to the US for a form of tethering surgery called anterior scoliosis correction. And Simon Cowell actually paid for it out of his own pocket. But a couple of years later, after Simon Cowell forked out £175,000, she was back for a fusion because essentially her spine became kyphotic, even though she had a reasonable scoliosis correction from the technique. And so there's this variability in outcomes. I suppose what we don't see are things like as much with tethering is things like PJK and PJF and these things that you do see with fusion. So there are of course risks of those procedures as well we have to consider. I suppose other things we need to look at, and again, sort of published from Feroz Mianji in the Harm Study Group and Peter Newton, is will the lumbar curve spontaneously correct as well if we do a thoracic tether versus, say, a thoracic fusion? So what we know is that in a flexible lumbar spine, say a Lenke 1, Lenke 2 type curves, where you can just fuse the thoracic and let the lumbar self-correct, called spontaneous lumbar curve correction, we get pretty good corrections of those lumbar curves, usually over 50%. So a big question is, do you get as much with VBT? And the long and short of it is you get some, but not as much. So they only correct on average in the lumbar curve by 30% at 2 years versus in most studies on selective thoracic fusion, the lumbar unfused curve corrects by at least 50, if not 60, 65%. So I think that's a potential downfall to the technique as well. It means you have to watch lumbar curves very closely or consider operating on a lumbar curve with tethering that you may not do if you were doing a fusion. Another big issue with tethering highlighted by Per and Steph de Paz from Germany is that they are we're looking at x-rays and we can't always tell where the tether breakages are. So this has maybe implications for future care. And so they've done a study where on revisions, they were looking at where the breakages are versus where they could detect them radiographically. And Petra Bush is very experienced in this area and published a lot. And basically by using a rule which we use where you look for 5 degrees of angulation between the screws, they only detected about half of all tether breakages. Now that could also be because the tether is doing its job in those cases. It's actually modulated the growth and, the ends don't splay apart because it's actually worked at that particular segment of the spine. But our radiographic assessment is fairly crude. You can see tethers on an MRI or CT, but it depends on how it's sliced, and it's not that reliable in my experience. So hybrid is a concept born from sort of the failures of tethers, I think, and I think sometimes innovation it comes from necessity. And this was my first hybrid case I did a few years ago. So this is a girl who had a double major curve pattern who was treated within Australia by another surgeon with single row VBT. And she had the parameters required for VBT at the time of the procedure, and it was indicated appropriately. And this was her initial result. I mean, to look back on this, I'd say that the thoracic curve, perhaps should have been tensioned a little bit more. But with a single row, there is a limit to how much tension you can apply to the cords or tethers used in these cases. So, look, a reasonable early result. Unfortunately, she went on to break her lumbar tether in a number of spots. And you can see the lumbar curve is really progressing here. And this is at about 18 months after surgery. So I talked to them. I mean, patients go through this procedure because they want to preserve motion. And I really wanted to avoid fusing this young lady down to L4. So this is a pre-revision film. And I don't have the side benders here, and I should, and apologize for that. But she was quite flexible still in the lumbar spine. So I also felt here that her shoulder imbalance was driving the lumbar curve progression. And that we probably needed to aim for at least a tiny bit more thoracic kyphosis. So after much discussion, being aware of the possibility of further revision, ended up doing this surgery. And so this somewhat goes against the previous paper of fusing more levels. We managed to just fuse the thoracic spine only, get the shoulders level, and then I re-tethered the lumbar. So essentially this result's been maintained at 2 years. So by correcting the thoracic, we've driven the lumbar back around. I've added in another row of tethers and an extra level. And we'll hopefully be able to preserve mobility there. In the more mature child, when she came to revision, I'm not sure if it's going to hold, but there are lots of surgeons out there that do break the Lenke rules with selective thoracic fusion. Sometimes, if a lumbar curve bends down to 30 instead of 25, they may still try selective thoracic fusion. And I suppose that's the principle that I'm using here, is trying to drive that lumbar spine around by a aggressive thoracic correction in both planes. You have to correct both coronal, sagittal, and to some extent axial planes when you do this surgery if you really want to get that lumbar curve around. So yeah, there's a lot of enthusiasm for tethering, and it's been discussed at meetings a lot, so many publications and presentations. And I suppose something that has really changed people's perception was this paper from, again, Amir Sandari's group in Philadelphia, where they've used motion detection tracking on a huge group of their patients that have had both posterior spinal fusions to various levels and vertebral body tethering to the same levels, and they've matched them. And although they found that in the VBT cases there was slightly more motion, it wasn't really clinically significant or that detectable until you take your distal fusion level to below L1. So what they're essentially saying, and the selective thoracic fusion concept, is where you stop a fusion, you just say T4 to T12, or L1 is included in that. So if you do T4 to L1 as a posterior fusion procedure, and then you compare that to a patient that, say, had, and four is hard to get to with tethering, but let's say T5 to L1, the functional motion that they could detect with their motion capture cameras was not substantially different, and they didn't feel it made any clinical difference. So that really changed practice for them. They say in the paper that they changed their practice as a result of this, and that they're less inclined to offer tethering because of the higher revision rate for thoracic curves. And they've published in Journal of Neurosurgery the sort of the next step of this. So we still know that lumbar motion is really important. And I think every one of us who practice out in adult spine land, and Andrew, feel free to jump in and comment, but we see patients that have been fused, particularly to L4 as teenagers, coming back with problems. And they are hard to deal with. And often they're coming back in their late 30s or 40s. So they actually do well and they get discharged from the pediatric service, and they're coming back 15 years or so later. All right. So when the when this happens, I think, it's always a difficult conversation, difficult situation. I think we also have to remember that scoliosis runs in families, and so some, parents, mums in particular, have had surgery, and they don't want the kids to have the surgery that they've gone through. So the hybrid concept basically works by taking some of the risk out of tethering by doing both curves, and some of the risk out of lumbar fusion deep into the lumbar spine. So this is a case series of 20 patients with 2 years follow-up treated in Philadelphia, and by and large, their results were very, very good. It makes for longer procedures. You have to turn the patient, or you have to do it in a stage fashion. But this was their hybrid experience, and so far the results here appear to be excellent. But again, with all these things, time will tell. I presented a very small series of over 1 year follow-up of my own ones of these. Is just 3 patients presented at the Spine Society of Australia this year, also with excellent overall results. But I have found that you can extend the indications a little bit with this. So this is a 14-year-old female who's a basketballer. She's Sanders 6, so a little more mature, Lenke 1AR, and she's got idiopathic scoliosis essentially, but had this old issue with the mild dilatation of the central canal. And, is it a syrinx? Is it just normal? We don't quite know. She's perhaps a little bit kyphotic for AIS. And she's got this long sweeping curve. And I think a lot of people, to make a beautiful X-ray to L3, here we've been able to get away with fusion to L1 by just using a tether to stop that sort of falling out to the right and adding on that these patients get. And so, I recognize this as off-label use, but we are expanding the indications for this by keeping fusion levels shorter and hopefully keeping more function, particularly in the lumbar spine, while correcting the main problem at the thoracic apex. So this is another recent case of a 14-year-old female. She's got a 75-degree thoracic, a 58-degree lumbar, and she's Sanders 7. Now, again, her lumbar spine's really flexible, but she bends down to 28 degrees. And, Lenke rules would say that she needs to be fused, and a lot of people would take her low. Andrew, have you got enough of a read on this case to tell me what levels you do?
Yeah, I'd probably go low on this. Probably.
Yeah.
I might consider all 4, but I don't like to.
Yeah, exactly. I don't think that's unreasonable. I mean, many great surgeons, including Andrew, is going to consider L4 on this. There is you can sometimes get to L3 on these curves by doing an anterior release and really making that lumbar spine flexible, combined with Pontes. Yeah, it's uh, it's a potential a long fusion. So this is what we're able to do for her with a little bit of luck. And she's also got a leg length discrepancy, right? So that also plays into this. And for some reason, the orthopedic people haven't really wanted to treat it sitting around that 2 centimeter mark. But I think having a flexible lumbar spine is helping her accommodate for her sort of pelvic obliquity there as well. So that is that's a recent case that I've done, and we've been pretty happy with that. What are your thoughts, Andrew?
It looks really good. I mean, I don't do vertebral body tethering right now, but we might start having to. Looks really good.
Yeah. I'm sorry, my computer's. I'm just going to pause the session for 1 second. I just got to get a PowerPoint. My computer didn't charge overnight.
I was going to ask, hey, Andrew, how are you?
Good. How are you doing?
Good, good. Yeah, I was just going to I'll ask Mike when he comes back. So, I've been following the clinical work and the literature on this. I find, I've always found this VBT option really interesting. It really never made a lot of sense for me in the thoracic spine, but I wanted to verify with Dr. Selby what I'm thinking he's getting at, which is it makes a lot of sense in the mobile lumbar spine so that you don't fuse a mobile segment. In the thoracic spine, it really never made much sense because they're just not really significantly mobile segments, right? So as he was saying, why put a patient through a 15-20% potential risk for a revision? So yeah, I think it's interesting. I wonder whether everybody's is heading in that direction as well. Hey, Mike, how are you?
Hey, Hallie, how are you?
I
Yeah,
don't
thanks for
know if you
joining.
heard.
Sorry,
Yeah, no
I,
problem. This is
I
really
did hear
interesting
that.
topic. Yeah, very,
Yeah,
very
look,
interesting topic.
well, I agree with you, and I think that's again what Amir showed is that as adults we don't actually use our thoracic spines a lot day to day,
Yeah.
and so that's where it's important to have these conversations with patients and their families. And I suppose I've really flipped what I do as well in that unless someone wants to be, say, an elite athlete, like an elite swimmer, rower, volleyballer, basketballer, but I got lots of basketballers running around with selective thoracic fusions as well. But, I think if someone wants that really high end flexibility and they're prepared to take a chance and they meet the criteria, I will still tether thoracic spines, but I've really dropped off in how many I do. And I've probably increased the amount of lumbar tethers I do in the same period to avoid those long fusions possible. So, this is my I mean, we got to wait and see because basically this case here, and I don't know if you saw the pre-films, but she bends down to 28, right? And so, the Lenke rules say, well, we shouldn't be, and she also has a curve above 50 in the lumbar with significant rotation. So I would never blame people for fusing her to L3 or L4. Never. But this is a new concept, and I think these tethers in these patients will eventually break. But we are relying on the fact that by driving that thoracic around, the lumbar curve will come with it. And I think Larry Lenke came up with 25 degrees kind of from experience, not from any defined, really well-defined research prior to that. I'm happy to be corrected, but 25 degrees was sort of a number that he said, this is our experience and when these curves can come around. So on the side benders. So yeah, we'll see what happens with time. I think everyone of us doing these surgeries, we just got to keep reporting our results because people need to know what's happening if we want to change what the structure is. All right, so this is another case I put up on LinkedIn, but this is a really challenging case for me because this is a young girl who was Sanders 4. She's got this big curve, but she's also kyphotic, right? So she's got a combination of scoliosis and kyphosis, and that kyphosis is essentially Sherman's. She's got Sherman's changes on her MRI. And, she's got a pelvic obliquity as well. So a lot of these patients, they've got lumbar pelvic obliquity. And if you fuse these patients deep into the lumbar spine and their pelvis is oblique, again, I see them running into trouble down the track. There's a lot of stress and shear on those discs. And so, she's a lot better. And this is her at about 18 months after the procedure. So she's had a fusion down to T12 and tethering down to L4. And her alignment is not perfect, but she's much better than where she was, and she's kept some mobility in her lumbar spine. And then the
I
good
got
thing
a question for you. Do you
yeah,
do these, how many days is it the same setting, or how many days apart do you do those procedures?
I started doing them as separate because I wasn't quick enough to get them all done, and now I do them the same day.
Okay, got it. And that's what I was going to get to. Do you feel that after you correct the thoracic spine, especially in cases like this, do you feel that it does make a difference to doing the lumbar right away versus waiting 6 weeks or 12 weeks to see what happens to the lumbar spine? And maybe you need a different approach in the way you tether it versus, no, it doesn't matter. I'm going to tether it the same way regardless, so there's no point in waiting.
Yeah, look, I think I'm probably going to tether it the same way regardless, but I've had some cases where, again, it's been borderline and we haven't wanted to go in the lumbar spine at all. So after a lot of discussion, we decided to just do the thoracic and see if we would come back and do the lumbar down the track. And look, I mean, the lumbar tether is a pretty good procedure, but to do T12, you've still got to get super diaphragmatic. You don't need to deflate the lung. But you do have to use a small chest tube afterwards. So, there is that extra sort of hit with an extra tube coming out and, extra time in the ICU. When you go L1 down, you can usually go subdiaphragmatic, and that's a lot less invasive. I have had a couple of cases where we've decided, okay, to sort of break the lanky rules again and go for a selective fusion first and see what happens to the lumbar curve at 6 to 8 weeks. And I've done that a handful of times, and I think about 60% of the time we've gotten away with it, and about 40% we've ended up coming back to do the tether in about 6 to 8 weeks. So it's certainly doable, and I don't think there's anything wrong with that approach. There are, when patients sort of are flying in for surgery from other parts of the country, sometimes it is nice to just get it all done in one admission for them. So that's just another consideration that I've got in this, because I do end up treating people from all over Australia. So yeah, I think we're going to hear more and more about this, just like at all the meetings, and Ali, you've been there for this, SRS meetings, all the meetings is very much about tethering for some period of time. And now we're starting to see more and more hybrid papers going up. So yeah, so it gets a bit confusing because this is another hybrid. This is a Prius, which I think people are familiar with. But hybrid also can be used to describe apical fusion, usually in the thoracolumbar or lumbar spine. And so this is a case from overseas who had VBT, initially reasonably successful, but progressed, particularly in the lumbar spine. And she came to me with broken tethers, so we revised her. But just revising her when she was already mature at this point, to repeat tethers is always doomed to failure. And this is what happens when you open up. This is the old Zimmer Dinesis system. And basically you can see that the breakages in the tether there. These are little sort of screw caps that we pulled out and replaced her to the Globus system ended up using with some apical interbody cages. And you can see her lumbar curve is improved. It is not perfect, and she might still need further work, but she was really keen on avoiding a long fusion deep into her lumbar spine. And this has been holding on for a while now. And we are happy enough with this. And this is the thing you have to accept with tethering, is that I know I can make X-ray look beautiful with screws, rods, ponte osteotomies at the back of the spine. But people are pretty happy walking around with curved and functional spines. And so that's where you have to get your head around the concept of function versus radiographic beauty, basically. And look, the apical concept, I credit Bertrand Bush, but really it's recycling of an old concept. We used to do a lot of short segment anterior fusions for thoracolumbar curves, often bone on bone, tribute to Bob Gaines and and others. There's a UK surgeon called Hall who did a lot of short segments. Australian surgeon called Dwyer who invented this thing called the Dwyer cable. Should find some x-rays of that. That's a great piece of equipment. But they were all anterior surgeons. They were doing mainly bone on bone, occasional cages, and really often got very, very good results. And I think the advent of powerful pedicle screws and Ponte osteotomies and sort of Harry Shufflebarger's technique and papers sort of killed that off basically for a while. And the skills were somewhat lost, unfortunately, in a lot of centers, not all centers. So the anterior approach basically relies on controlling the apex. And what we've come back to with vertebral body tethering, particularly for thoracolumbar and lumbar curves, is that can be important. And so this is a recent paper from Petra Bush in the European Spine Journal, published January 24, on using an apical fusion to reduce the rate of tether breakages. And he's compared 15 patients with pure VBT and tends to use a double row like I do in the lumbar spine versus 10 patients who also had an apical fusion. And pretty dramatic difference in tether breakage rates. Long-term follow-up found that 60% when you don't do an apical fusion had at least one broken tether. Now, that doesn't always mean revision. In fact, most of the time it doesn't mean revision, particularly if it happens late, but still a high breakage rate versus just 1 or 2 cages around the apex. So a fusion at 1 or 2 levels, the tether breakage rate is down to 10%. And that's probably because of controlling the apex, detensioning the tethers at a couple of levels, and the tethers just put over the top of interbody cages. But being kids, they tend to fuse straight through cage with a bit of bone graft, and they fuse pretty quickly. So for a thoracolumbar approach, this is the typical incisions I use. This is my previous resident, Karim Kantar, who's finished now a couple of fellowships overseas, including with Feroz Mianji. He's on his way back to Australia. He helped me with a bunch of these cases when I was getting started. And this is the 3 incisions. You can see a little distal oblique incision, one at the thoracolumbar junction, and a port for the top screws. And this is us putting in the screws and safely going in, X-ray guidance, and just checking where we are. And it's a little bit of good old orthopedics in there, hammering staples into the side of the vertebral body. And then we pop the screws in through the same approach. Again, it's a fluoro heavy. You can do it with navigation. It is hard because of the mobility of the spine to get a good reference point. So I tend to still use fluoro for these. And this is the case. So to go with about
Mike, I know there's sorry to interrupt, just a quick question.
Yep.
I know this is a very easy answer for you, but I've always thought about this, is where, especially since this is fluoro heavy and you're not really having direct visualization, how do you know you're not injuring the segmental vessels?
Oh yeah,
how do you know if you're above them or below them?
No, I have directly seen the segmentals and either push them down. So if the vertebral body is quite big, you can lift the little periosteal flap and push them down in them. In a small vertebral body, you just take them.
Okay.
And if you're in
so when you're putting these screws, you always have to visualize them to either mobilize them or take them.
Correct. So I've visualized the side of the vertebral body, peeled back psoas or the crus or the pleura if you're in the thoracic cavity. And I've either pushed the segmentals up out of the way or I have taken them. And then really the staples and screws go in under fluoro after you've established your entry point under sort of direct vision. So it's a combination of fluoro and direct vision. But yes, you are going really blind to the other side of the spine. And some people use less fluoro by using either that PediGuard device. I don't know if you've seen that. I don't think it's common in the US, but there's that PediGuard device which gives the high-pitched noise when you're coming out of the bone. And that can be quite useful for these cases to reduce the amount of fluoro shots you use. Also, your navigation has been described. I think Noel Larson has described it, how to do it. But the issue I've got with navigation for this in particular is the mobility of the spine, and you do a lot of leaning on the spine. And I think, unless you're able to get a true segmental registration, navigation is pretty challenging for this. to set up, but I'm very open to good ideas about how to do it better. Very, very open, because I'd like to be able to reduce my fluoro dose for these cases. Right, so this is the case. So this is this young lady. She's got a single cage here. Actually, she's just been fused at the apex. These are her 18-month post-op films or so, and she's balanced. She's got a good overall spinal balance. We haven't dramatically changed her sagittal profile. I think she's got a bit of a kyphotic neck, and that's probably normal for her. These cages, I've CT'd the odd one. I try to avoid CTs in children, but we've had to for some reasons, and they fuse really quickly. I don't mind using a titanium cage that everyone can see. Some people use peak cages, so it doesn't look like a fusion's been done. It just looks like a plain tether. But I think, the titanium cages to be fused pretty quickly. So this was a happy result so far. Again, I think it's on all of us that do these cases to report our long-term follow-up, because tethers break, things can change. And what we want to see when these tethers break, if they do break, is a maintenance of that spinal posture long-term. So this is a kind of hybrid concept, but I call this apical fusion with tethering around it. And there's another recent case of a bigger curve. And this kid is actually eligible for a tether. He's Sanders 4. He's got this 50-degree sweeping long curve. His MRI is normal. So this is idiopathic scoliosis, although it's a boy, not completely typical, and he's got a little bit of thoracic kyphosis. So, again, this is a challenging case, because if you're looking at fusion levels on this case, it's a young guy who enjoys sports. He's got this rotation going deep all the way down into the lumbar spine, right? And that always worries us when we're choosing distal fusion levels. I think for me, if I was going to do a fusion here, I'd probably go to at least L3. I think L2 is a bit of a risk here, and that's not disastrous, but it is somewhat limiting. And so then just able to utilize these concepts for a curve like this. Now, 3 or 4 years ago, I probably would have just done a straight tether for this kid, and I critically look at my results, and I've got very similar curves we've treated quite successfully, but there's been a couple of tether breakages. And so I was talking to the family about this option, and in the end, this patient's got a 3-level apical fusion. So they've got interbody cage, you can see at 12.1 and 11.12, and they're flattish cages, a little bit of lordosis on the bottom one. And then at the level above that, there's actually a bone-on-bone fusion, Bob Gaines style, a bone-on-bone, but supported with the tethers. And the tethers are solid enough that in a kid that fuses quickly, they will support the cages and the bone-on-bone while it goes on to fuse in the vast majority of patients. And so, look, this patient so far, so good, and is doing okay. We've just I've got a whole bunch of these, but again, this is another patient, and X-ray is not perfect, but they're really happy. This is a young lady who came in with a lot of pain and a lumbar curve. She's hypermobile, skeletally quite mature, and we've gotten away with here at about 18 months, a 2-level apical fusion. And we're monitoring that thoracic curve, and she has no pain there, and she doesn't want anything done. And she's aware we might have to come back and fuse that later on. So, one good thing about modern navigation is that if we have to do a thoracic fusion, we can usually navigate around these screws okay, or you can use short screws, you can just put them up or down a bit. So the vertebral body screws don't exclude posterior fixation. They make it a bit challenging, no doubt, but they don't exclude it if you have to do it. So I think that's the end of my sort of Cook's tour on all these little things you can do with hybrid surgery. It's evolving space, and I'm sure we're going to hear a lot more about it over the next few years. So thank you for joining me. Thank you, Andrew, and thank you, Ali, for joining in. And happy to take any questions.
Fantastic talk. I think it's super interesting. Like I said, I don't have a ton of experience with it, but yeah, really good results. I think really promising. And Dr. Bowden was saying, I think it makes a ton of sense in the lumbar spine, thoracic spine. We get into adulthood, not super flexible, but I think if you can save some motion in the lumbar spine, it's gonna pay dividends down the road, so.
Yeah, I think that's what we're all coming around to is that, yeah, the thoracic fusion, a beautifully well done thoracic fusion is going to give good results for, 95% of your patients. And it's just now that tethering got so popular out in the sort of patient parent community, you've really got to highlight the cases of doing well. I mean, I've got a young lady I operated on about 8-9 years ago who's in an international surfing contest this week in Brazil. She's fused from T4 to L1. So the local news are doing a story on her, and so I think it's good to sort of put those stories out there because a lot of parents in particular think that a thoracic fusion is the end of the world, and it isn't. And it gets good results. But I also recognize that the sort of elite end of dancing, gymnastics, perhaps swimming, having that thoracic motion is good. And so there'll always be a bit of demand for thoracic tether. Certainly don't do nearly as many as I used to.
Very nice. Yeah, nice job. Nice job, Dr. Selby. I think this is, like you said, it's an important topic. It's an evolving technology. I can tell you when I was practicing in New York not too long ago, a lot of families were coming to different centers, as you know, in that area, just looking for this procedure. And it did teach me one thing, because I do quite a bit of obviously anterior cervical surgery, some arthroplasty, where certainly a lot of people say, well, why are we doing arthroplasty? Like, and my answer is probably won't be different than what you're presenting here, which is if you know that there is a technique or a solution to a problem like scoliosis, and let's say one is not inferior than the other, or they're equivalent, one is not necessarily superior than the other, but if a family and a patient and a parent, for whatever reason, is requesting one or the other, you should be able to provide both. And I think that alone is really a good reason to know how to do this and to be able to offer it. Now, hopefully the results down the road will show that perhaps at the thoracolumbar junction or in the lumbar spine, non-fusion is better. But if for no other reason, I think it's great that you're providing access to patients and families who want that option. I think that alone is a good reason to really tackle this. So yeah, nice work, and I know we're going to keep seeing a lot about this and hearing a lot about it, and we'll see where that pendulum wants to settle in a few years.
Yeah, absolutely. I did see recently, I think a European surgeon's been doing posterior tethering. So using this concept at the thoracolumbar and lumbar junction posteriorly, which is attractive in some way because it's putting in pedicle screws through our normal plane. They're probably using the Wiltse plane, safer. I would caution against doing that in the thoracic spine because it's going to not create kyphosis, pulling on a cord at the back on the concave side of the curve is going to be producing an iatrogenic flat back. And so, I think it's kind of out for thoracic, but if it was done carefully in the lumbar spine or the thoracolumbar, you could potentially get away with it. So I'm really interested to see those long-term results as well.
Wonderful. Thanks, Mike. Thanks for everybody who joined us. If I don't see any questions in the chat box, so if there are no further questions, we'll conclude the session and see everybody next week. Thanks, Andrew. Thanks, Mike.
Thank you.
Take care, everyone. Have a great day.
Have a good night.
See ya.